Hello, everyone, and welcome to this presentation from the COPD and mental health series. This is an IPCRG initiative supported by an unrestricted educational grant offered by Boehringer Ingelheim. My name is Catalina Panaitescu, and I am a family physician living and working in Bucharest, Romania. I have a special interest in respiratory health, and I am one of the two founders and coordinators of the Romanian primary care respiratory group named Respiro, which is affiliated to the IPCRG. With me is a colleague from Greece. Izolde, I think it's better to introduce yourself, please.
Hello, my name is Izolde Bouloukaki. I'm a primary care consultant in the Greek NHS. I also have special interest in respiratory diseases such as smoking cessation and sleep disorders.
Thank you, Izolde. We will be your hosts for the next 30 minutes or so, during which we will approach what we think it is a hot topic, the tobacco dependence in COPD patients, and how can we help them in primary care, especially when mental health issues are also present. If you will find our slides useful, please feel free to use them in your presentations, as long as they are not commercial and you cite the source as mentioned here. This is a short glossary of abbreviations we used. And we will start with a general introduction to COPD and mental health, followed by a case study in order to highlight the importance of smoking cessation in people with COPD and anxiety, and provide an evidence-based intervention example through a clinical case. What we aim with this presentation is to emphasize the importance of evaluating smoking status in people with COPD and anxiety, to identify the main barriers to smoking cessation in these patients and appropriate methods to overcome them, and also how to apply a structured smoking cessation intervention in these cases. Will the limited time of a primary care usual consultation allow all these interventions? Absolutely, as long as we use a systematic approach. We know that smoking is the leading cause of COPD, and that smoking represents the most effective intervention in stopping the progression of disease, and therefore in increasing survival and reducing mortality. However, even treated with a combination of counseling and pharmacological therapy, many of these patients continue to smoke, so reasons may need to be looked for in more depth. What else do we know about COPD? That it's often associated with comorbidities that might influence the smoking cessation process and which require special attention in this context. I'm talking here about anxiety and depression, which are common in COPD patients and at the same time proven to be associated with cigarette smoking. So what we have is a cumulative effect associated with poorer health status, increased risk of exacerbations, more often emergency hospital admissions, and as a consequence of all this, a higher risk of death. Smoking cessation in people with COPD and mental disorders raises several issues because these patients are more addicted to smoking, more likely to relapse, require support for repeated quit attempts, and usually have a lack of confidence and self-esteem due to previous failed attempts. Moreover, many of them consider smoking as a way to manage their mental symptoms, ignoring the fact that quitting smoking actually reduces anxiety and depression. Let's invite now in our virtual primary care office a patient. He's 67 years old, recently retired from a taxi driver job, quite sedentary by the nature of his former occupation and the type of activity he has at home. He might not have noticed immediately that he has a problem if he hadn't been trying to keep up with his 3-year-old granddaughter. Now he is in our office, and we know from his medical file that he has COPD, hypertension, hypercholesterolemia, and one episode of transient ischemic attack a few years ago, which really scared him, so that he takes, as told, the prescribed cardio and cerebrovascular medication. As for the respiratory treatment, he's not so convinced because he considers that his bronchitis only bothers him when he gets a cold. And the last time this happened was a year ago when he went to the emergency room where he was prescribed a new treatment, but didn't need to be admitted to the hospital. He still smokes and is overweight. The reason he came is to get a prescription renewal. Now, what we do? It could be a busy day, and you know that this is usually the case. So we could decide to ask the patient how he feels, asking no specific questions, and let him to choose what he considers it's important to tell us. Then make a clinical exam, give him some general recommendations, and remember that we tried several times in the past to propose him to stop smoking, but he wasn't interested, so we just tell him that smoking isn't good for his health, renew his prescription, and that's it. Or we could choose a different approach, which will not take longer, but will help us not to forget important questions to ask, and that it was proven to have a better efficiency in terms of achieving therapeutic goals. Structured assessment of symptoms, risk of future events and comorbidities, then the clinical exam, the very brief advice for smoking cessation, and Izolde will tell you more on this, and finally the renewal of the prescription. The GOLD report recommends to assess COPD patient symptoms using either the MRC dyspnea scale, either the COPD assessment test. Here on the MRC dyspnea scale, our patient has a score of 2. On level ground, he walks slower than people of the same age because of breathlessness, or have to stop for breath when walking at his own pace. The COPD assessment test offer more information, not only on dyspnea, but also on other aspects related to the quality of life of our patient. He might not be limited in doing any activities at home because, as we saw, he usually does not much, but he's not comfortable when he has to leave the house. He does not sleep well, and he feels like he has no energy. Using the combined COPD assessment of patients, our patient is in group B. He had an exacerbation in the past 12 months without being admitted to the hospital, but because he continues to smoke, Izolde and I decided to explore more the risk of future events. And we know that smoking is a major factor in COPD exacerbations. That previous admission for exacerbation is a strong predictor and can identify patients at risk. So our next step will be that recommended by the evidence, which is strong to suggest that smoking cessation is a key intervention for smokers with COPD and should constitute a core element of long-term management of these patients. And now, Izolde, I would like to ask you to continue the consultation of our patient.
Thank you, Catalina. An easy, positive, and effective way to help tobacco users to quit is a very brief advice. It works at every point during clinical consultation about another health matter. In this case, the reason for visit was prescription renewal. It contains three elements: ask, advise, and act. Ask to establish and record smoking status, advise on how to quit, and act to offer help. In our case, we asked our patient if he is still a smoker, and he responded positively, saying that he smoked 15 cigarettes for about the previous 40 years, without any previous attempts to stop smoking. We asked him if he knew what was the best way of stopping smoking, and he said that he hadn't really thought of that till now, so he started having second thoughts. And we also asked him if he would like to talk about the options available to help him with tobacco use, and he was positive, and he started to be motivated and said that this would be helpful. However, we should take into account that mental health problems such as depression and anxiety are common, as already mentioned, in COPD patients and may influence smoking cessation success rates. This desktop helper regarding COPD and mental health aims to raise awareness of the challenges of identifying and managing mental health illness in COPD patients. We have to consider that apart from the physical symptoms such as poor sleep, impaired concentration, headache, we could also use validated questionnaires to assess mental health problems, such as the World Health Organization recommended Patients' Health Questionnaire 4 for very brief measurement of depression and anxiety. This is an easy tool that can be completed online. Question 1 and 2 are the General Anxiety Disorder 2 Anxiety Subscale, and question 3 and 4 are the Patient's Health Questionnaire 2 Depression Subscale. A score of above 3 indicates further evaluation. In our case, the score is 6, so further evaluation is indicated with more specific questionnaires, such as the Patient's Health Questionnaire 9, which is used to assess depression, and it has a cutoff score of 5. Then General Anxiety Disorder 7 questionnaire, which is used to assess anxiety, and it has a cutoff score of 10. The Fatigue Severity Scale, which is used to assess severity, frequency, and impact of fatigue on daily activities. A score of equal or above 36 indicates fatigue. The Athens Insomnia Scale, which is used to assess the severity of insomnia, and the score of equal or above 6 is indicative of insomnia. And the patient sleep, sorry, I have to stop. And the Pittsburgh Sleep Quality Index, which assesses sleep quality and patterns of sleep during the last month, and the score of equal or above 5 is indicative of poor sleep quality. However, in our patients till now, there was no formal diagnosis or screening of these disorders for these patients. So we have to consider barriers to the assessment of mental health problems for people with COPD. There are patient-perceived barriers such as lack of knowledge, reluctance to disclose symptoms of anxiety or depression due to social stigma related to mental illness. There are physician-perceived barriers such as lack of a standardized diagnostic approach for anxiety and depression, of course, time constraints, and lack of confidence to pursue in-depth psychological assessment. And there are also system-level barriers, such as poor communication between primary care and mental health systems, and lack of adequate resources for mental health treatment. In order to address these barriers, an integrated treatment approach is required from healthcare professionals, patients, and caregivers. Getting back to our case, we have some positive things and some challenges we have to face. The positives are that the patient is up to date with his vaccination. He has a good relationship with his doctor. He adheres well to his other medical regimen, and he really wants to try to stop smoking. The challenges are that he has 3 comorbid conditions, including cardiovascular and cerebrovascular disease, in addition to his COPD. He takes 4 medications every day, plus his reliever as needed. He does not like to take too many medicines. He has a low adherence to the COPD treatment. And based on the questionnaire score, he has a general anxiety disorder with no previous formal diagnosis or appropriate management. What are the next steps? Motivational interviewing is an intervention that is maybe useful for patients to change harmful behavior. We have to clarify that doctors are not judgmental about tobacco use, and we have to explain to the patient that we know how hard this is and that this is an addiction and that nicotine is more addictive than heroin. We have to encourage the person to imagine and communicate what he thinks might be the benefits of quitting. We have to explain and tell him that if he quits smoking, he could have fewer bronchitis episodes. He will likely feel much calmer, more positive, have a better quality of life, and he may also be able to fall asleep more easily and sleep for longer once in bed. And we have to consider positive reinforcement to motivate the patient to quit smoking. And we have to explain that if he quits smoking, his energy levels will maybe increase and he will be able to be around for his grandchildren. What will be the management plan? Of course, we will provide counseling, as already mentioned, with empathic understanding and respect. We also have to implement the very brief advice with ask, advise, and act. Of course, we have to discuss pharmacological treatment, which is really important, such as nicotine replacement therapy, varenicline, bupropion. We have to assist with developing a quit plan, including setting a quit day. Intense follow-up is really important, and we have to schedule a next review date. Of course, it's not easy in a busy primary care environment, but email, text, or phone are really helpful for follow-up sessions. We have to discuss abstinence and suggest coping strategies. We have to encourage social support and the partner or family to be involved in these appointments. We have to assist in dealing with barriers such as fear of failure, dealing with stress, weight gain, and social pressures to smoke. We also have to provide advice on nutrition, physical activity, and sleep hygiene, and provide advice on managing withdrawal symptoms and reassurance that they are all short-lived. Patients it's common for patients to be reluctant to take medication, but we have to explain that adding medication for mood disorders to a standard program of smoking cessation may achieve better long-term quit rates, and we have to consider initiating treatment for this patient for his general anxiety disorder. To sum up, many people with COPD continue to smoke despite evidence that smoking cessation is the most effective intervention in increasing survival and reducing morbidity. Tobacco smokers with mental health disorders tend to be more addicted to smoking, smoke more cigarettes, and are more likely to relapse. Anxiety and depression are common in people with COPD and should be actively evaluated and treated. The take-home message is that smoking cessation reduces anxiety and depression. People with COPD and mental health disorders who smoke often need support for multiple quick attempts, and combined counseling and pharmacological treatment is the most effective intervention. I want to thank you all. I want to thank Catalina. All this material will be in the EBCRG web page